Good morning. Welcome to the critical appraisal session on behalf of Clinical Epidemiology Unit. So in continuation with the last week's session on critical appraisal of a diagnostic accuracy study, as Sir had mentioned, we are going to have a series of sessions on diagnostic accuracy. So today we'll have a critical appraisal of a systematic review meta-analysis of studies on diagnostic accuracy. So I'll once again hand over to Dr. Anna, and where she will be focusing on the Quadas 2 tool for assessing risk of bias of the accuracy studies. Over to Dr. Anna. Thank you so much.
Thank you, sir. Okay. So as Dr. Vignesh has already said, we're looking at a critical appraisal of a diagnostic accuracy, systematic review, and meta-analysis. So we'll be looking at the Quadas 2 checklist in addition to some few other things, which I'll come to. So like always, let's start with case scenarios. So I have 3 case scenarios for you. So case scenario 1 is a 34-year-old gentleman with 1 month history of headache, low-grade fever, weight loss, night sweats. His CSF is showing high proteins, it's lymphocytic predominant, his MRI is showing basal exudates. Case 2 is a 25-year-old lady with history of headache on and off for the last 6 months with recent worsening. No clear alarm features, has lost some 1 kg over the last 3 months. CSF, some mild protein elevation with some 7 cells. Case 3, 50-year-old gentleman with fever, coryza 2 days, followed by some headache, mild confusion of 1 day. No comorbidities. CSF is showing some lymphocytic slight elevated cells, and protein is also slightly elevated. Okay. So now this study I have looked at to answer what we should do for those case scenarios. This is a recent Cochrane systematic review and meta-analysis. It's looked at low complexity automated nucleic acid amplification tests for extrapulmonary tuberculosis and rifampicin resistance in adults and adolescents. Okay, this was published fairly recently and it's an excellent review. So now the appraisal tool that I'm going to use, we're mainly going to be concentrating on the Quadas 2 tool. But the Quadas 2 tool is specifically for risk of bias assessment and applicability. So that part, I'm going to concentrate on the Quadas 2. But for systematic review at large, I'm using the CASP checklist for the systematic review. Last time we used a CASP checklist for the diagnostic study. This is for the systematic review. Then there's reporting guidelines. So last time for diagnostic study, we looked at the STAR-D, which is the reporting guideline for diagnostic study. For this, we have the PRISMA diagnostic accuracy thing. I'm not going to be going into that in great detail. So in CAS, first, like always, you have to check if the results are valid. Was the study conducted well before we then go to look at the results? So did the study address a clearly focused question? So yes, the population they looked at were adults and adolescents. So they defined as age 10 or above with a presumed diagnosis of extrapulmonary TB. The index test is a low complexity automated nucleic acid amplification test. I'll come to what that is later. The reference standard was microbiological or a composite outcome. That is for the extrapulmonary diagnosis. And for rifampicin resistance, the gold standard was a culture-based drug susceptibility test or a whole genome sequencing. The target condition is extrapulmonary TB and rifampicin resistance. So did the authors look for the right types of papers? So yes, you can't really use a RCT because again, so in a diagnostic study, you can't say some people got this test, some people didn't. So you wouldn't take an RCT. So you take cross-sectional and cohort studies assessing for the diagnostic accuracy against the reference standard that we had already explained, which is microbiological composite outcome. They excluded case control studies. Now it's important for why? Because if a group of people you think has disease, then some of them are positive, some of them are negative. That would be what a true or a real life scenario. So if you take case control, which means you take a bunch of people who already have extrapulmonary TB, or you take a bunch of people who have some completely different diagnosis, and then run the test on that, it does not replicate a real life scenario. So therefore, that would be a case control type of study, and you usually shouldn't include them. And they had not included that. They excluded them. Case reports, were excluded, and they excluded patients who had gastric fluid or stool specimen, because traditionally those are actually markers of pulmonary TB. Therefore, they did not include those patients. Now, so do you think all important and relevant studies were included? So children was excluded. They had taken adolescents where they counted 10 or above. And again, for children, you take gastric for pulmonary TB. It's not a marker of extrapulmonary. So this review is for extrapulmonary TB. So therefore, it's excluded. Actually, they've done quite an extensive database search. They've covered most major databases. There was no language restrictions. They looked at clinical trial registries, all this till October 2023. They have also done forward citation. They have looked at ProQuest dissertations. They've contacted experts, manufacturers to see if there's any unpublished or ongoing data. And there was also a WHO public call for data with which they collected some data and some unpublished data as well. So I thought they've done a pretty extensive search. So now, did the authors do enough to assess quality of the included studies? So they did the Quadas 2 checklist. So that's what we will be going through this session. So before I come to that, what is Quadas? So it's the quality assessment of diagnostic accuracy studies. So currently we're using the Quadas 2 tool, which has 4 domains, which I will be coming through, which looks at risk of bias and applicability. There's actually a Quadas 3, which is in development, which is trying to modernize it. So because there's a lot of AI, there's a lot of more rapid tests, automated tests coming in. They're trying to incorporate that into the questions. And one concern with Quadas 2 is interoperable judgment is not consistent. So they're trying to correct that as well with the Quadas 3. Maybe sometime next year, CU session will be on that. There's also a Quadas C, which is basically a head-to-head diagnostic accuracy. So so far we've been talking about there's an index test and there's a reference test. But if you're comparing, say, ProCal versus NGAL for sepsis, those are two tests which you're comparing head-to-head. Then you have a Quadas C, and there's a QPAS, which is a prognostic accuracy study. But here we're looking at the Quadas 2. So Quadas 2 has a phase 1 where you have to state the review question, which we have already covered in the CASP. So I'm not going to go through this again. Phase 2 is draw a flow diagram for the primary study. So Quadas is actually like an ROB tool. So like you use the ROB tool for RCTs in a systematic review. So Quadas 2 is for risk of bias in each individual study. So if the systematic review had 30 studies, they have to look at each study, they do a Quadas tool. So I've tried to give Quadas for the study as such, this systematic review as wherever I can. So the flow diagram is not for the individual studies. This is for the overall systematic review. So they had actually already conducted this review in the past. So they had 11 studies from previous. They had 571 records, which they screened through databases, and they got 4 additional records through the WHO public call. 224 records after removing duplicates. Of these, 149 were excluded based on title abstract. 75 full text were accessed for eligibility, and in that they had irrelevant index text, couldn't form a 2x2 table, did not contain extrapulmonary. These were all there. Some of case control was one. These were excluded in the full text screening stage. Finally, they got 26 new studies plus the original 11 from the previous review. And they totally had 37 studies for the systematic review part, and of which 36 had data they could extract and were included in the meta-analysis part. So now, so that was the initial 2 phases of Quadas. So now comes to the main part of Quadas, which is phase 3, which looks at risk of bias and applicability judgment. That has 4 domains. So the first domain is patient selection. So the first question is, was a consecutive or random sample of patients enrolled? So this is how that final risk of bias tool is presented. So you have all the list of the studies. So they have, for each domain, there's a risk of bias and there's an applicability area. So in the risk of bias for patient selection, you can see there were actually 6 studies that had some concerns. So most of it was low concern. Few had unclear selection method and one had an inappropriate exclusion. Therefore, they have downgraded. And because I'm looking at it overall, since 84% were good, I said yes. the consecutive sampling was collected. Then was a case control design avoided? Yes, I already went through why you should exclude them, and they did do that. Now, did the study avoid inappropriate exclusions? So this was the review's exclusion criteria. So I said in the previous slide that they had excluded one study for inappropriate exclusion that they found within that particular study. So I'm looking at it overall for the review. So they said relapse cases in previously treated extrapulmonary TB was excluded. That alone, I thought, okay, maybe that was it, but all the others were reasonable. So they said gastric, juice, stool were more for pulmonary TB, therefore they didn't include it. Rare forms, so cutaneous, ocular, genital, breast, ear, parasynal TBs were excluded. That also maybe some concern. And if they had fewer than 5, so when, say, for example, lymph node TB, only 4 patients had lymph node TB, then that was not excluded, so which seems reasonable. And if they were not able to extract a 2x2 table, these were excluded. So overall, I think some concern, but I think it's a probably reasonable exclusion criteria. So now, were there any concerns regarding applicability? So that the included patients do not match the review question. So they had, the authors, based on their thing, had said 1/3 had low concerns, but some had high concerns because all the patients were recruited only from tertiary care. And the clinical setting was not reported in some of them. But overall, I think for us, like most of our patients with extrapulmonary evaluation do end up coming here, although I guess for for lymph node and pleural, that might be different. They did include studies that had children, but they had specified that at least 85% of the population has to be their required population. So that's okay. And they did exclude rare pulmonary TB. And in terms of prior testing, they said symptomatic screening, chest X-ray, C-reactive protein might have been done, which is what you would expect, like before you start thinking pulmonary TB. Histology and cytology, I feel, is little too specific in terms of your diagnosis. But overall, I think this is a fairly applicable test. So in the domain patient selection, could the selection have introduced bias? I gave it low. Is there concerns that the included patients do not match the reviewed questions? That was no. So the next one is your index test. So I'm going to explain what is a low complexity automated nucleic acid amplification test. So actually WHO classifies these nucleic acid amplification tests based on how complex it is to run. So like it's a simple machine, big machine, whether it's a point of care test or it needs a large reference lab, or whether it can be done like this manually. You need to pipette, you need to do various steps versus the machine does the whole process. So in that you have low complexity automated, you have low complexity manual, and then you have moderate quality automated, which is usually in these reference labs. So in the low complexity automated ones, there are 4 that the study has looked at. So the most common one that we all know is Expert Ultra. So that's what we are also using. But there's a TrueNat MTB that was actually by a company in Bangalore. But overall studies have shown it's not as great. And there were only 3 studies of that. There's also the standard M10 and iron qPCR. This is actually not yet commercially available. It's only under evaluation. But that actually gives you resistance for up to 10 drugs. So when it does come, that will be a great test. Only 2 studies were done on this iron qPCR and standard M10. One was an ongoing trial on pulmonary TB, and the other was a case control. So they were not excluded. And there were only 3 in the TrueNat category. So were the index test results interpreted without knowledge of the results of the reference standard? If a threshold was used, was it pre-specified? So they actually give you each study, we've looked at it as well. But here, as you can see in the index test, for Ultra, there was like no risk of bias. And there was only 3 TrueNat. They also didn't have any risk of bias. So overall, I've also given yes. So now then there's a concern regarding applicability. Is there concern that the index test, its conduct or interpretation was different from the review question? No, I thought it was, it's an expert test that needs to be done and it's an appropriate test in this context. So risk of bias was low. concern of applicability, there were no concerns. The third domain is your reference standard. So what was the reference standard that they used? So they have used two reference standards. One is your microbiologicals. That means the culture positive, either solid or... But then, as we all know, there's some limited sensitivity to cultures. A lot of our tests do end up being positive. So understandably, they have also used a composite outcome. So that is culture plus some other supportive things. So that means imaging, like in TB meningitis or histology. And they've also specifically mentioned that for pleural TB, if histology, as previously literature has shown, that histology has a higher yield than culture. So that also seems reasonable and what we would be using on a day-to-day basis. For rifampicin, because they had included both of that, rifampicin was based on culture-based drug susceptibility testing, which is as WHO recommended, or in some studies, they had actually looked at whole genome sequencing. So were the reference standard results interpreted without knowledge of the results of the index test? So they have given one study had high risk of bias, and 9 of them had unclear risk because they had not reported it properly, or if there was decontamination of sterile culture. So that means you're killing the bacteria. So that might actually change your testing. So if they were inappropriately decontaminated, they have given that as a reference standard might change. So the main study that had the high risk of bias, so this was done in believers actually. So what they had done is it was a convenient retrospective sample. So they actually knew what the culture results were, which is why they gave it a high risk of bias. But overall, most of them were pretty good. So my answer for this was yes. Is there concerns that the target condition as defined by the reference standard does not match the review question? No. I think that this is the most appropriate reference standard that they could have selected. So in the reference domain, risk of bias was low and concerns regarding applicability was also low. Now the fourth domain is flow and timing. So this I have not divided into each question separately, but the questions under it is, was there an appropriate interval between index test and reference test? So now this mostly comes where, for example, you do a procal and then you say in sepsis, and then you take the culture 48 hours or 72 hours later. The culture may come back negative because you've now given antibiotics. So were the tests taken at the same time? But in this case, mostly your culture is taken from the same sample. So I don't think that's a concern here. Did all patients receive a reference standard? We'll have to go through it. All of them did. Did all patients receive the same reference standards? So they have divided the patients into composite and only microbiological. And were all patients included in the analysis? So they only extracted the studies which had a 2x2 table. So yes. So with regard to flow and timing, I don't think there was any risk of bias. So now with that, we're finishing with Quadas 2. So we have looked at the domain and the risk of bias overall we think is low. So now we sort of come back to the CASP. So if the results of the review had been combined, was it reasonable to do so? So was it good to do a meta-analysis? So they only conducted a meta-analysis if at least 3 studies were there. So if only one study talked about something, they just gave it as a narrative report. They didn't combine it in the meta-analysis. And they needed at least 30 cases. So at least 30 lymph node TBs were there between those 3 studies. Then only they gave you a pooled result. And they gave you separate specimens. It's not like they pooled all extrapulmonary TBs together and said whether you did CSF or you did bone TB, one same sensitivity. They've actually given it to you separately. And based on reference also, composite outcome versus microbiology, also they've given you separate outcomes. And for rifampicin resistance, they only looked at true culture positive on which they could do the. So I think it was reasonable how they have combined it. Now, one thing is there's something called class level analysis. So that means here you've combined all low complexity automated tests, which actually has 4 things. Finally, they had only 2. Now, they had predefined what they would combine. So you needed to have a certain specificity and sensitivity and a reasonable confidence interval to be included. So the 3 TrueNAT studies finally didn't end up being included in their final analysis because there was only 3 studies. And the positives were low in that. And their sensitivity, specificity, and all fell outside their pre-specified range. So most of the results are only for the expert ultra. So now we come to section B, which is what are the results. So here you need to look at what are the overall results of the review and how precise are the results. So here I've just looked at the results part of the Prisma DT just to see what are the things that they should have reported. So did they basically study selection as a flow diagram that they have already given to us? The study characteristics, did they provide a table with, okay, what were the patient characteristic clinical setting? Have they given that? They do. I'll show that in the next few slides. Did they do a risk of bias? They've done Quadas, which we have already gone through. Now, do they give results of individual studies as a 2x2 table? They actually do that. Synthesis of results, do they give you a combined sensitivity specificity with confidence intervals? They do that. And did they do any special analysis to look for understand heterogeneity? So they have done a subgroup analysis and they've done a meta-regression analysis as well, which I will go through. So this is the summary of studies. So they've given you this table. So the author, the country in which it was done, the median age, the clinical setting, target condition, index X, and the number of specimens. They have actually given it for each of the studies. This is their forest plot for each study. So you have like each study listed here. They give you true positive, false negative, true negative. Sensitivity, specificity with confidence interval is provided for each thing. Now, this is actually the forest plot for cerebrospinal fluid compared to culture. So the outcome was culture, the reference was culture positivity. Like this, they have given for every single thing. So CSF culture, CSF composite, pleural fluid, pleural biopsy. So it's actually very extensive. I've only provided the CSF results in the interest of time. So now this one is actually looking at CSF versus composite reference outcome. And the second one is actually in a subgroup. So people living with HIV, we know that might change your results. So they have actually done a subgroup on people living with HIV as well. Then they've done something which is called a meta-regression. So that is like in your regular study, how you would do a regression analysis where you're accounting for confounders. Here they've done they've tried to account from the confounders based on all the studies pooled together. So they looked at whether the concentrating of the CSF fluid changed the sensitivity and specificity. So they've again compared it to microbiological reference standard and a composite reference standard. And they found that concentrating the specimen increased the pool sensitivity and specificity a little bit in the microbiological reference standard. They've also given how much fluid, how much CSF fluid also, whether it changed the sensitivity and specificity. So these are all predefined and these are all very reasonable or what you would also be interested in knowing. So then they give you this summary. So that means your pooled sensitivity, pooled specificity, positive predictive value, and negative predictive value for each of this. So you have cerebrospinal fluid against a microbiological reference standard, cerebrospinal fluid against a composite reference standard, and with the number of studies. So they have pleural fluid, pleural tissue, lymph node aspirate, lymph node biopsy, urine, bone. So they've done a very comprehensive review. Okay, so for the interest of today's thing, I'm mainly concentrating on the CSF fluid. So for CSF fluid, with the reference standard of microbiology, it had a 88.2 sensitivity and 96.0 specificity. When you compare it against composite outcome, that means culture may not have been positive, but based on your overall thing, you had 60% sensitivity and 99.2% specificity. They then give you a summary of findings table. So this is a summary of findings for CSF, and the reference standard here is only culture positive, not the composite one. So the pooled sensitivity and pooled specificity. They also give you different prevalences. So remember last time we had discussed that your positive predictive value and your negative predictive value changes based on your prevalence. So they have actually given you values at different prevalence points. So you can interpret it accordingly. Now, this group, so the true positive, false negatives are the disease positive group. This is the disease negative group. So now when we do grade for a diagnostic study is slightly different from grade for a other systematic reviews. So it still has the same 5 domains, but how you interpret it is slightly different. Now, one thing is you don't need RCTs. Remember previously, you have RCT itself, your grade is high and then you downgrade. Whereas here in a diagnostic study, you can't do an RCT. So you don't have to downgrade for that already. The second thing is you have 2 outcomes. So you have to actually look at sensitivity separately, specificity separately. I'll come to that in my next slide. The other thing is they don't give you a direct number needed to treat or a direct patient outcome. So you have to sort of interpret the test based on the sensitivity, specificity, or likelihood ratios. You have to interpret that to give it a score. So you have your risk of bias, which is we're doing Quadas, not ROB. For indirectness, you look at one patient setting, so that might change. So if you're looking at only tertiary care, you might have a higher prevalence. If you're doing it in a community setting, you might have a lower prevalence. So that might change your indirectness. And your number, because you don't have a direct effect, for that also you might have to downgrade for indirectness applicability. Inconsistency, heterogeneity can vary between sensitivity, specificity. I'll come to that. And imprecision, again, you get confidence interval, which is separate for sensitivity, specificity. And of course, you have to look for publication bias. So it's a bit of a crowded slide, but basically I want, because this is a doubt I had as well, why is sensitivity and specificity reported separately? So that's because sensitivity, if you remember from last week, we look only at those who are true disease positive, or that specificity is only in the disease negative group. So what happens is the 2x2 table, this arm can be different and this arm can be different. So how does that happen? So if you take, here they have excluded case controls, but say your controls were all patients who came to headache to neurology OPD. So obviously your population there is different. So then you can't grade it the same, and that would only affect your specificity and not your sensitivity, because sensitivity is only among the disease positive group, right? So that can change. So your 2x2 table can change based on where you collected the patients from. Imprecision. So your confidence interval, as you know, is based on your sample size, right? So if you've taken from hospital setting, you're likely to have a lot more patients who truly have extrapulmonary TB, or at least in the composite outcome, you're more likely to diagnose that. So that also might change. So you're likely to get a more narrower confidence interval sensitivity if you did it in a hospital setting. Whereas if it was a community setting, you're likely to have a lot more true negatives, therefore your specificity might improve. So your confidence interval also changes there. And indirectness, again, this similar thing where you're taking it from a tertiary hospital or from a community center. Because say, for example, in CSF, yeah, okay, they'll all be in the hospital, but it could be a lymph node. The biopsy can be done as an out in the primary care or secondary care. So, but can you apply the same sensitivity, specificity there? Changes. So that's why you need to look at both of it separately. Okay. So here, back to this slide, they have given for sensitivity, which is the first one, grade of evidence is high. For specificity, they have downgraded it. And here they explain why. So now the specificity ranged from 50 to 100. So that's actually from this slide. So if you look at this, your sensitivity, almost all are falling, like the confidence intervals mostly overlap. Whereas here your specificity can be, some are here, some are here. There's the heterogeneity in the specificity is a lot more on this slide. But they have explained that, saying that this consistency was based on decontaminating specimens. So basically, if your reference standard is, here the reference standard is culture, right? So if you decontaminate specimens that didn't need to be decontaminated, then you're destroying the bacteria. So your culture might not become positive. So they felt a lot of that heterogeneity there was because, or the major outliers were in populations where the reference standard decontaminated the specimens. And the confidence interval was a bit wide compared to the sensitivity. Therefore, they have downgraded by 1. So now comes to section C, which is, will the results help locally? So 10 out of this 36 studies were from India. 84% of them were from high tuberculosis burden countries. 2 of the reviewers were from India. One is actually from CMC. Jefferson from PubMed actually was one of the reviewers for this study. So reasonably, I think we can extrapolate this to our population. So were all important outcomes considered? So they didn't specifically look at patient outcomes. They didn't look at the cost analysis. They've not done a time to diagnosis. So yes, it takes only 90 minutes, but it's not like our expert is coming back in 90 minutes. It just still takes 3 days for that result to come. So patient-related outcomes was not looked at. And often in a diagnostic study, that's something that is not easy to look and people don't look at. So the next question is, are the benefits worth the harm and cost? So here, like I said, you can't calculate a number needed to treat. So this has to be interpreted by the person who's doing the study. So let's say this is a highly specific test. So you can rule in the disease. If you remember from last time, SPIN. So specific, you can rule in the disease. So expert comes positive. You're saying, yes, this patient has TB. You can start treatment. So you might be getting treatment done earlier. So I think, and I'm sure everyone will agree, that that's a worthwhile test, because especially since culture, all that takes some time. Sensitivity, on the other hand, is only 60% for a composite outcome. So that means your false negative. So if it's 60% sensitive, that means 40% are falsely negative. So you can't really rule it out. So if 40%, if it comes back negative, you can't say, okay, you don't have TB, go home. You still have to do additional tests. But because the specificity is so high, personally, I feel that this is a test that is worth the cost. So now let's come back to our case scenarios. So case 1, 34-year-old gentleman with 1 month history, basically high risk for TB, headache, low-grade fever, weight loss, night sweats. His CSF is showing high protein, lymphocytic predominant, MRI brain showing basal exudates. How many of you think this is TB? Everyone's saying TB. Expert is negative. You're going to treat, or we'll all treat? Right. So here it's not a sensitive test, and your pretest probability is so high that you're going to treat. So now I'm going to come to case 3. 50-year-old gentleman with fever, coryza, 2 days, some headache, mild confusion. How many of you think this patient has TB? All of you think TB. Expert is positive. Will you treat? But it's a specificity is 99%.
Because probability is 1%. No, because probability, if you say low, and feel like your ratio post-test probability only comes.
But it still goes quite high. So I'll come to that. So case 2, so this is that sort of in-between thing. So 25-year-old lady with history of headache on and off for the last 6 months with some recent worsening, no clear alarm features, has lost about 1 kg over the last 3 months. CSF, some mild protein elevation, 7 cells. Do you think TB? So what is your pretest probability? 60%. Okay. So this is where we come back to what we discussed last time. So what is the most clinically applicable thing? So sensitivity, specificity is there, but how can you apply it in a clinical thing? So that's where you have your likelihood ratios come in. Okay, so I'm looking at the for composite outcome, because that is what we practice. So you have your sensitivity is 60.3, specificity is 99.2. So can we calculate the positive likelihood ratio? Yes. Anyone? With sensitivity divided by 1 minus 75. Yeah, so your positive likelihood ratio is 75. Okay. Now, can we calculate the negative likelihood ratio? So I got 40. I mean, so around that. So 40 or 0.4. Okay. So now, remember, I had shown this table last time. So if it's a positive likelihood ratio, so the higher the positive likelihood ratio, the evidence can be strong. So more than 10 is very strong. So the test results greatly increases the likelihood of the disease. When it comes to your negative likelihood ratio, 0.5 to 0.2 is weak. The test results modestly only lowers your likelihood ratio. So we'll apply this to the Fagan's nomogram, which we had discussed last week. So this is your Fagan's nomogram. So we all said around 50 to 60, correct? That's what we said for case 2. So if the test comes back positive, okay, so in that case 2, if the patient's test comes back as expert positive, your pretest probability from 50, if you go line through likelihood ratio of 75, goes up to 99. So if this patient expert comes back positive, you're 99% sure this is TB. Now for case 3, we said we weren't sure. So what was your pretest probability there? 20 or 10. Okay, so even if you look at 10, I don't have a line for it. Please, this is like, so if you go from 10 with a 75% pretest probability, that still gets you to almost like 95% probability that this patient has TB. Now, if in case 2, expert comes back negative, so then what happens? Your pretest probability stays the same, right? We thought only 50% probability. Then it's 0.4, so around 0.5, you go. Your post-test probability becomes 30. So from 50, it became 30. And the sensitivity of this test is only 60%. So can you say that this patient doesn't have TB in case 2? No. So here you will have to use your clinical judgment. So, okay, what did the MRI show? What is other pictures? That CRP is high, MRI showing basal exudate, you might say CRP is normal, patient has no symptom, no CRP is not elevated, then you might say, okay, let's keep this patient on follow-up. So in that case, you would have to use your clinical judgment. Okay, so I'd like to acknowledge Dr. Tambu and Dr. Vignesh.